takes at least 30 minutes probably to populate.
So you don't have to repopulate pages. So really, it's a task tracker for each of those. So we've put there's 3 buttons for common tasks, and then so the blood, chest X-ray, whatever.
It's not just about the task, isn't it? When your hands again.
Oh yeah, sorry.
I mean, obviously this is, it's just built in isolation, but there's no reason why it can't be modular, can't pull information from other systems that already exist in hospitals. So whatever inpatient management software, would be able to populate name of patient, where their location is. So you have that as a background. If our system had seen them before, it should also retain their comorbidities, so you don't have to enter that data as well. So again, 2 things that are more advantageous than a word processor. And then jobs, it's just as simple as clicking on common jobs or writing it in there and add jobs. So it should become more efficient over time if you can plug it into other systems that already exist.
Can I just add something? Yeah. So one of the best things about the system compared to the Word document system is that the Word document system is locked to one user at a time. Everybody else will just end up with read-only copies. This you can be updating in parallel, so 4 or 5 people can be updating the list rather than just...
I'm not trying to defend Word documents.
I appreciate that. I'm just saying that's one of the biggest benefits of the system.
It's not only that this has come up multiple times, but also you've also had a similar project here today about managing this task. So did you actually work with them at all, or talk to them about what they were trying to do?
So we sort of fed off each other actually, and I was sort of giving some advice because I think they've already gone some way ahead because they're using their system in their hospital. I think the thing
I think one of the key things they were talking about was the integration with the. I mean, you are asking Amanda how you're going to manage to do this integration, but that's really the problem. I think why these don't kind of manage to get on.
Smart on Fire can't come quick enough as far as I'm concerned, and that has to be. We've got to stop moving. We've got to move away from all these different systems. There has to be a single API language that is used. I'm told that Oxford, apparently, where I work, is going to be the first place to properly open up their Cerner Smart on Fire, which is planned for later this year. I don't know if that's actually going to happen.
So also wonder why Cerner or the big suppliers not actually have this functionality already?
Well, the functionality is there. They just won't open it up. That's up to
No, for the patient list.
Yeah. So interestingly, I've certainly worked with sort of trusts that use Cerner and other sort of electronic patient records, so things like eOasis, etc. They have a list function, but this function has come as a secondary objective. It's not their primary focus, it's almost an afterthought. So it's really not been designed ergonomically with thoughts to being very easy to use, very accessible. And that's why we still use this, majority of us, to this day. So whatever solution you come up with needs to be better than this. And the only way we can do that is by having something that's so user-friendly, that's been built very much around the user. And that's kind of what we tried to get around today. That's been our design process.
If it's come up so many times, it's clearly a big problem.
Yeah.
So that would be my argument, is it's a big problem.
No, it's not criticism.
No, at all. No, I'm just
that
saying.
the people that are watching realise this.
Yeah, I mean, we'd love to see what, how everyone else would tackle this problem and see if there's any sort of commonality over that,
All right, thank you. So it's self-trust, patients,
Why did someone close it?
Can switch laptops again. I didn't close it.
From the other Chrome tab. Been closed.
Okay.
Okay. So we are the chemo triage team. Problem-wise, we start with the problem with when you're a chemo patient and you're having treatment, you get a number to call in case you feel unwell in between treatments. And in my experience, it's very difficult to get through the line. So it's obviously a risk for patients that are experiencing infection or something because they're delaying their treatment. And so this is basically a solution to kind of get some self-triage before the line is has a lot of traffic and stuff. So.
Just very quickly, we've got 2 endpoints. So we've got a web service which was based on Vanessa's old project. She'd already told us that she had a kind of flow chart type system, so we forked that and just adapted the flow chart, and then we'll give you a demonstration of the second input. But basically the idea is that we farm off the obvious please come to hospital immediately things, because that's where the best bang for buck and kind of lowest risk, because if something's obvious, someone obviously needs to come to hospital, get that first, and then they don't tie up the phone line. So if they've got chest pain, they come straight to A&E. If they've got fever, they come straight to A&E or the input, and there is a whole list of different scenarios which will allow them to self-triage.
Yes, basically, I forgot to mention, but we based our work on this phone triage system that was developed. So it's like not everything that is here, obviously, because it's huge, but part of it, at least, so the beginning is, yeah.
All right.
So then, so as well as the phone app or the website, there's also a phone line that you can still call the phone line. And
you have a trial account.
We'll get past this trial account business first.
Press any key to execute your code.
And this is where we start.
Welcome to the chemotherapy line. Are you experiencing any chest pain? Push 1 for yes and 2 for no. Do you have a fever or a temperature over 37.5 Celsius? Press 1 for yes and 2 for no. Do you have signs of an infection, such as burning when passing urine, coughing up anything, or any shivering or shaking? Press 1 for yes or 2 for no. Do you have any of the following 5 symptoms? Press 1 for shortness of breath, 2 for a rash, 3 for bleeding, 4 for mobility problems or numbness, or 5 for urinary problems. Press 6 for none of these. Do you have any of the following 6 symptoms? Press 1 for diarrhea, 2 for nausea, 3 for constipation, 4 for ulcers, or 5 for pain. Press 6 for none of these. Have you had more than 6 episodes in the last 24 hours? Press 1 for yes or 2 for no. You need to speak with someone about your symptoms. We can transfer you or store your phone number, and someone will call you as soon as possible. Press 1 to transfer now or 2 for a callback. Transferring you.
Through to the call center.
That's it.
Questions?
Yeah, for something as serious as like, I might need to go to the hospital straight away, do we know how comfortable people feel with communicating that information via some kind of automated type system? Would people always rather speak to someone in person?
I think it's a good question. I personally wouldn't mind getting this information if it was faster than my experience getting this information. I had to wait. Yeah, if I could get it from a machine fast instead of waiting live for 30 minutes, I would choose the machine.
And one of the reasons we try to do 2 different things is because people do like getting information. Some people are always going to phone through regardless, but some people might be okay with using a phone because they don't have a smartphone or texting, because the same sort of Clio endpoint allows text as well. Or they're happy looking at websites. So I think it's about giving people choice, and then rather than focus, then forcing everyone to use the same service.
I was going to say something similar. It felt a little bit maybe impersonal depending on your situation. But I wonder if I don't know, have you got enough details to arrange a callback if I don't complete the call flow in the system? Because then sort of call someone back and think, well, they haven't completed that.
We were kind of avoiding storing patient details, so there's a balance.
But yeah, you can do it. I mean, it really allows you to, as soon as they're connected, you get their phone number, so you can store that if you need to.
Yeah, I don't know how much of a question this is, more of a proposal, because at the last NHS fact I did the exact same thing. It wasn't for cancer, it was very much more general, and it was for when patients reach A&E. So I guess the kind of question is, do you think it's better to have this kind of system at home rather than at the hospital?
So I mean, so then had this experience as a patient. I've worked on an oncology job, so I've been on the other end of the phone as well. And I think the idea is that there's actually a few common complaints that people come up about, and there's always a hotline to an oncology ward that they can call. And actually, when you have a couple of simple questions like whether they're feverish or that kind of stuff, and you can triage a lot of people very quickly, very early, then that potentially reduces the risk. And so if we do want to speak on the phone, then when they get through to an oncology nurse, it's not like a general kind of hospital line. They're not waiting half an hour for the last 3 people to come speak.
Okay. I guess the second part of my proposal then is, can I come with you guys to finish work on
But yeah, if you look at the presentation spreadsheet.
Sorry, what's your idea, the idea at the beginning that the patient can self-triage themselves? Sorry, decrease in that?
Yeah, so we just took one profile, one route through it, but depending on what you say, it will give you advice on to actually pack some things and come to the hospital.
Maybe you don't want to call. You were trying to solve the problem of spending too much time on the phone and so on. The nurse might still be busy and might still end up spending half an hour, although we've gone through those questions. Yeah. I'm asking, is there some sort of thing to remind you what the doctor said? If you have people beyond that time, just go to the hospital. Maybe a combination of the
yes, we're not going to take through every single combination, but through some of the things it will say, if it's actually nausea and vomiting, it says take your antiemetics as prescribed regularly, and then call back if it gets worse. And for a couple of the other streams, it does have advice, and that's both on the phone app and this.
From the technical perspective, how is it to change the route? If, for example, you want to extend it to some other condition or some other use case, then do you need to rewrite the application in order to replace the written text and answers, or it's just flexible and can be done by one technical person?
So the website, the kind of web version, that unfortunately they don't work off the same API, which would be quite a nice thing. They're both kind of separately, they're kind of parallel, but actually this flow all comes from just a static JSON file, which is fairly human readable, so I think most people will probably be able to clone something fairly similar. And again, I think you found it pretty easy with the Twilio documentation. So
yeah, the documentation, although it's kind of the branching was custom for this. If we could have written a general thing, maybe we'd have still been here tomorrow writing a generalized route.
Hi guys, hope you well. That's it.
Hello everyone, I'm Neil, I'm an ophthalmology doctor, and me and my colleague Pei, who can't be here right now, wanted to try and come up with a solution to a problem that we face on a regular basis as eye doctors working in urgent care. So we've had the fantastic help of Vanessa, Ivana and Helen. What we wanted to do is try and create some help for us as we work in urgent care, because often ophthalmology is a bit unique. We work on our own quite a lot, and especially out of hours. You can be a junior doctor or a locum doctor, and you might have just turned up in your department and not really know how things are managed. And most of our conditions we manage as outpatients, so we start the treatment and we send patients off and arrange a follow-up plan. And that follow-up plan's got to be pretty tight, because if the patients don't come back in the correct time, don't get the right treatment, they can end up with irreversible sight loss. So we really care about this. And what's really important as well is when we're on call, we often cover multiple hospitals. So I work at St George's, and we cover Kingston, Epsom St Helier, and Croydon, and a lot of different hospitals. So what we wanted to know was, how do the consultants prefer their patients to be managed, and what's the subspecialty provision at these different hospitals. So that's really what we wanted to create, was a guide for doctors to use. Because if patients get the wrong treatment, they obviously end up with poor consequences for themselves, but they get increased cost to the NHS because they need extra appointments. And the current guidelines that we have are just a big PDF document. You might have all seen those types of things. You get into induction and you're just given this massive PDF document to scroll through. Difficult to find information, it's difficult to update. So we came to these guys for help and asked for a user-friendly solution that would really get you to the right, so we could get the right treatment, but also just get the right follow-up. And it would give you not just how to manage the conditions, but what the consultants want doing. So there might be only a glaucoma clinic that runs on a Tuesday and a Thursday, but if you send a patient back on a Friday, they're not going to get the right care. So we wanted to add that information into the guidance as well, and also contact details for the consultants for these subspecialties. And what was important to us was that we all move around quite a lot as junior doctors, and we wanted it to be easy to edit. So when new doctors come in, they want to change the guidelines and update them, it should be very easy for that process to happen. So myself and Pay started with these PDF documents that we'll just turn up, we'll give the documents, and they can put that on an app. But I think we were quite wrong in our approach, and these guys sent us in the right direction. So we put with a little sketch, and then magically, these guys sorted us out.
So we decided to make a kind of a static website that would take all the information from the PDFs in the form of markdown files that are data format that's relatively easy for non-technical people to edit and write. That could be converted into a website for them. These are some wireframes we drew. We drew initially just to show what it might look like. You would just get on the home page, you'd see the big categories of conditions. This is assuming that the junior doctors already know what the diagnosis is. They just need guidelines for that trust, how to treat the patient. They can go in and in 2 clicks get a document and get all the information rather than going through the PDF. That's what it looks like.
Thanks for the shout, what it looks like.
And it's mobile friendly, so that when they go, they can just easily go to it on their phone, and within 2 clicks they can find all the information. And what's key is that this is all managed. All this information is produced as HTML pages or markdown files that we taught the doctors how to write markdown, so they can populate the rest of the content however is easiest for them and update it easily, and the site will just fill out and be updated as they need it. And it's all their information from the documents.
So we managed to create a kind of skeleton framework that people like us who don't know how to do this can just stick the information in and then so that was the goal. We just try and get a kind of structure that we could then take away and work with.
So this solves your problem?
Yeah, I think we've done really well. Well,
Did this solve your
yes, I think it did. Yeah.
We're going to take it back and use it.
Yeah, we're going to take it back to Moorfields and say, can you please help us develop this a bit more? Because I'm sure it's about a gazillion meetings that happen now and to get this actually to be used. But it's much better than the current system. It's, if you print it out, it's this big tome of guidelines that, I mean, you can search within it, it's a PDF, but it's just not nice, you know, it's not nice. And even if this is just used on the internet, it's a much better way than it is currently. And what was key for us is having not just how to manage the conditions, but because a lot of our stuff is outpatient, subspecialty, you know, managed, it's no point sending someone back on the wrong day to the wrong clinic because it wastes their time and our time. But that's what's a bit unique about ophthalmology, is that when we need that communication long term.
This way, all that information will just fit in any doctor's mobile phone as they're running around the ward. They can just quickly pull it out and reference it really quickly.
Yeah, with the nature of the data lend itself to being able to automatically generate the markdown, so you don't even have to worry about that stuff.
In what step?
That's something we thought about, but the PDFs that they showed us were each of them were very different. There was a lot of information, and if you had to scroll through about 20 pages of irrelevant information to get to the information you wanted. And that's why they started, their initiative started making these one-page PDFs that had everything really easily referenced. So I think, yes, that is a possibility, but I think the current state of that information, the way it exists now in Word documents, PDFs, is very varied, and I don't know, we didn't know how to extract it automatically.
It's not a lot of data that we want to, I mean, it is a lot of data to transfer over, so it should be quite easy to update it. The other thing we wanted to do was add in a link to an email address for the consultant. So we often will say, okay, patient comes back in 1 week time, I need to email the consultant to just okay that and let them know. And if the consultant's email is at the bottom, then you click on it and it links up to your email. That's kind of our next stage of doing that.
There's been a lot of work done in primary care about trying to map out pathways for condition. Company in New Zealand, they've done a lot of work with pathways. They're coming over to here, and it's not so much usually about actually technology, but about getting people to agree what the pathway actually is. So it's a standardisation kind of process. We all agree that's what it is. And it's not just about burying the Word document, it might be out of date, whatever. We all care it's important to actually keep this up to date. But that's been sort of implemented in some places. It's going to be the same as the work. But I think that once you do it, then it could be really useful to do as well.
And I think what's great is that these guys have made it in a way that non-tech people can update it, and it'll look nice on the website, so that's credit to them.
Can you add images, any of your PDFs or images?
Yeah, well, we could do, I guess.
Markdown files are, you can add images, you can add links, you can add all sorts of things to them, and there's really easy tools to edit them online, and they can convert to HTML very easily. People who don't understand HTML, so you can do all of that, and these guys learned it in half an hour doing tutorials, so by the time it takes somebody to learn how to write a Word, they can write a markdown file.
So for, say, this condition, I managed to find a very detailed American Academy of Ophthalmology document, and I just put the web link at the bottom, and it works. So you dive into more detail if you want to.
Because this could almost be a vanilla system that you could use not just for your purposes, but for anyone who wants to.
That was very much part of it, because what we understood was that all different trusts might have different guidelines, and what we were told is that there's this day in August when junior doctors leave to university and they arrive for the first day at their trust, and they're like, here you go, these are the guidelines you have to follow, and they're really hard to parse and read, and this is a much more user-friendly way for them to have information at their fingertips when they're on the boards.
It's a very broad question, not about this implementation in particular, but I'm really interested to hear what it looks like from the doctor's perspective, versus the patient, with more and more assessments shifted into this kind of self-served systems. and references and automated word calls and everything. On the one hand, I can see how it can save time, my mail time included, but at the same time, I'm feeling as a patient a little bit uneasy because a lot of the possibility is delegated to me who isn't qualified. And what if I make the wrong decision, then who is to blame, and how this can be prevented? Because it's kind of a similar question. It's the same situation in many other industries, like who is to blame when a self-driving car hits a pedestrian, for example. So I'm just wondering what it looks like from the doctor's perspective, and if there is a discussion in the medical community about that.
Well, yeah, that's what we do every day. We make a decision based on our training, and if we're not sure, we go to guidance. So to have this published within our trust for our doctors, it'll have to go through a series of meetings and agreements between all the consultants before it's ratified and used. We wouldn't just stick it out there and let people use it. Yeah, that's not going to happen.
There's a theory on repo that this is not approved for clinical use, and that the intention would be to make it password protected for them to have an account to log in or password access it. These applications is for doctors.
Hi guys, I know this is the last talk, and actually probably the one that everyone's been waiting for, so and we're ready. My name is Mohammed Kaki, I'm a GP from North London. This is Sahil. He's a tech entrepreneur. We've got Kai, our programmer, and Simon, who's sitting idly at the back. So, Eat Well, great name. We're here to talk about a real problem. We've gone global, we've gone big today, because we thought we had a day and a half, let's solve all the issues. Global obesity, it's a massive issue. It's tripled since 1975. It has, I'm not going to talk to a room of clinicians and tech people and everyone who's read the papers and knows what's going on with any sort of patronising demeanour, but the facts are startling. 62% of adults, 2/3 almost, in the UK are overweight. 1 in 4 are obese at the moment. We're the highest growing rate in Europe and second highest in the world after the States. It's a health burden. It's also one of the top 3 social burdens after smoking and after armed conflict, both of which we didn't have the finances to deal with, so we've gone with weight. But amazingly, £27 billion is spent on the budget across the global spend, not just on health and across the whole societal impact. If we were to cut it just by 1%, the obesity burden or the overweight burden, we would be saving the whole global, the government, £300 million per year from 2035. So it's really, really effective, and those are stats you can see. Why? Because we live in a situation, an environment which is obesogenic is the medical term. What does that mean? It means everything's pushing us towards this environment. Food has lots of calories, there's much more available, there's all these deals going on. We live in a more sedentary lifestyle, we don't really exercise, we don't do so much. So what are we doing here today? Well, we've looked at this from the fact, yes, we've established as a problem, and there's a couple of solutions. Essentially, energy in is energy out, and your weight stays the same. But if energy in is too high, or energy out is too low, then we have a problem. But which is the better one to go with? Well, we had some talks and we had some discussions, but the BMJ meta-analysis told us what we need to know, which is it's multifactorial, but diet is the #1 thing you can change. On top of that, behavioural change coupled with that has an unbelievable impact. And supplementing all of the things that we'll be talking about, which is teaching patients about food, nutritional education. Coupled with that, app-based trackers are absolutely massive. You can see the figures of monthly active users, 25.4 million for Fitbit. So the question really is what were the biggest barriers? One more thing. What was the biggest barriers to use? And really, it's to do with the ease of uptake. People have all these trackers of all the things they need, but it's too onerous to take on all that food. So let me give it to Tom now.
So the idea here was of the one-click pick, and we were able to do a lot, but sadly we can't demo. So we integrated it with an image classifier, so something that could tell you whether food was hot dog or not, and you could snap a photo of your meal, it would tell you what was in there. But sadly we were lacking the budget for nutrition API to tell us what was in there. So the idea was you took a picture, you entered how big your meal is, something that we found we could automate with time, and from there you'll get your macronutrient breakdown. And the big thing about this is it's very easy to use. So the big thing is that it takes an awful amount to actually enter what it is what you're eating, either search through a database, or it's complex otherwise. And data visualization is massively effective. So as you saw before, it's about having the spoons there, because people don't look at numbers and they don't understand colors when it comes to scale. So it's all about data visualization. And we've got a full customer acquisition plan, which I know we don't have time for, so I'd advise one of you to ask us a question. So we can tell you our plan to scale this and our ICO. Thank you.
What was my question for you there? Sorry, what's your ICO? Is that it?
So, yeah, who in the room has heard of Sweatcoin? Anyone? So Sweatcoin is the third most popular health and fitness app in the US, used by tens of millions of people. And the idea of Sweatcoin is it's a cryptocurrency as you earn as you exercise. And the idea what we were thinking was something from eCoin, which was crypto that you earn as you eat healthily. And there are a whole bunch of other things that tie into this. So there are corporate incentives. If you hire people and you have healthier employees, you're able to provide perks. If you're an insurance company, you provide health insurance, life insurance, those premium goes down, you can have benefits through that as well. So we think this can be a hugely scalable way in terms of customer acquisition and getting people on board if, for just taking pictures of their food and learning more about it, they're getting real world benefits for it.
eCoin is not a chocolate coin.
So it's obviously quite complicated to do image analysis and calorie and food detection based on an image. I think MealSnap is one company that's trying to do that, and it turns out pretty hard. You mentioned, it could be a throwaway comment, but some APIs. Were there any out there that could do a bit of that?
Oh,
Yeah.
What's one? What's it called? I can't.
It doesn't matter what the name is.
So we use the Google Cloud Vision API.
We tried to do but it's too general, so it came up with stuff like it showed you the plate, that there was a plate there. And literally everything it could have possibly been, and it was the rice and couscous as well, which was a bit awkward. But there was another one, but it was like 200 quid a month, which is not influenced by territory at all.
Yeah, so the roadmap there was something called Calorie Mama, which was actually very good at isolating what it is was an actual meal. And unfortunately, we didn't have additional investment. But after that, we found the USDA was a little bit lacking. But there was another API from a company called Edamam, and they had really good nutritional breakdown if you were to input a meal. And beyond that, we found another API which was lacking time to look at volume estimation in terms of depth perception from smartphones. So when you take a picture of your meal, you were then able to estimate what size is that. So we had handfolds that we were using as our proxy to start with and user input. But beyond that, we wanted to move towards sort of volume analysis. So the tech is there, it's just having the time to build.
No, sorry, it's just a comment. Like you mentioned on Instagram where everyone puts their favorite food and stuff. Sorry, you get an alert.
Yeah, it's actually really good that you mentioned that. It's actually part of that was formed our reasoning behind creating this kind of concept, which was essentially we live in that Instagram generation now where everyone is snapping all of their food all the time, and actually it's become such a fashion that people find it much easier and much more amenable, and actually it's become much more socially acceptable to keep becoming, not eating, but taking photos of food and becoming slightly narcissistic. But essentially, taking lots of photos of things and imaging and documenting everything we do is becoming such a widespread thing. Coupling that with the research from meta-analysis that actually supports behavioural change and that diet is the key, we thought this would be a perfect solution for that population.
Things that are visually similar can have quite different numbers of calories, so how do you deal with that?
Yeah, certainly. So I think there's a couple of things we thought about. So we haven't had time to show the walkthrough screen beforehand, and there's a couple of bits we would add in terms of options to add condiments, things that are not mentioned here. So if you have an image, you can also add extra bits. So you might want to add, say, butter or teaspoons of that sort of thing.
In a restaurant meal, for example, you don't know what they put on it. So.
Yeah, and that's a really good question. It's one that we thought about. So I think the thing here is, one, you're looking to minimize user input, because the more laborious it is, the less likely someone is to do. And secondly, the same meal can have massively different calorific and macronutrient breakdown. So you have to have user options. So I think if you're able to isolate, say, having a slider or having a set of options in terms of fast food restaurant at one end to healthy homemade at the other, or something along those lines, it would have to be user input to start with, given that most of what exists out there tends to be scanning barcodes, where you already have the information there. So it's the best proxy you're able to get, really. Yes.
Oh yeah, just had an idea. Some extensionless location that I actually might want to use if existed. Maybe you know if this already exists, so you can point me in the right direction. So on the prepackaged food from supermarkets, on the back of it there is a fairly standardized list of the colors and the breakdown. That should be fairly easy to scan with a cloud vision or an API, because it's much cleaner and easier to recognize. So if we can parse this information from the back of the package, then we can be very accurate about the predictions and much more accurate than from actual photo. So I was just wondering if you thought about that as well, or if something already exists.
You mean scanning the barcode of the food?
Yes, yeah.
Yes.
So you don't need time to the weight then, and you can get the breakdown for your grocery shopping and yeah.
So that is something that already exists. Thanks for bringing it up, because we didn't have time to go through this. But I think one of the big things isn't so much the packaged food that people buy in the supermarket, but it's about the meals themselves that they eat, and it's about the portion size beyond that. I think a lot about changing behaviour that we're looking at here isn't necessarily so much changing what they eat, but it's about seeing the size of the food on the plate and whether what used to be a normal portion 15 years ago that might have been 500 calories is now 900 calories what they're eating. And although you're able to scan and see individual items, like someone might pick up a butternut squash or they might pick up a packet of rice, once that's cooked and that's put on a plate, it's a very different macronutrient composition to before. So it's definitely a little bit more ambitious scope. And then taking us back to here, that ties into the data visualization being effective, so being able to see what that looks like beyond just the red, yellow, green that you see on the back there. If you're able to see scale, so if a meal could only have, say, 10 grams of sugar, but you have a meal that has 30 grams of sugar, it's a lot more powerful seeing that in 6 green versus 2 than just seeing the colour red.
Thank you very much. Slightly,
and the fact that people are starting to look at their train times, and we are running. We might be. Thank you very much. That's great. I think we're now going to have the panel briefly retire